All right.
Yeah.
Well, listen, it's 6:33, so I think we'll go ahead and get started. Um, as I just mentioned, this is I don't even know the real number, somewhere in the high 20s, edition of our West Coast Fellows Conference. Um, and very pleased, let me advance my slide, to have one of our West Coast colleagues here, Safdar Khan from UC Davis Health. Our very first West Coast Fellows Conference was with Kleinberg from UC Davis, and we haven't had anybody since. It's been 3 or 4 years. And so it's really nice to have another of our West Coast institutions participating, hope to drive some fellowship participation or resident participation from the Davis group. Um, and really excited to have Safdar here, who I met not too long ago, but have just established we have a lot in common. He did his fellowship at Rush and also did a pediatric fellowship at Shriners, and is an alumni of Davis, where he did his internship and residency. So really excited to have you, Safdar. Welcome. Look forward to building more inroads with your institution. And spine biologics is something that I think can often be an afterthought, but obviously, has a big cost in our field and has a big implication and impact on our patient outcomes. So I'm really glad you've taken this topic on.
Thank you very much, Honey. And again, it is such an honor to be invited with this August group. I just arrived at UC Davis maybe 11 months ago from Ohio State. So it's just a phenomenal opportunity to reconnect and especially connect with everybody here on the West Coast. So thank you again, and really honored to be here. Honey, can you see my slides? Is
Yes.
it okay? All right, perfect. So we're going to go ahead and get started here. Really sort of talking a little bit about mastering the complexity of how we do biologic fusion in the spine space. And these are my disclosures that are relevant to this presentation, but the goal of this is to have an open discussion, which will be primarily data-based. So what I'd like to talk about today is to objectively assess the level and quality of evidence for different types of bone graft products in the marketplace and look at it through the lens of evidence, regulatory pathway, product variability, cost, and then safety concerns. And what can we as a group, this West Coast powerhouse group, with the residents, fellows, and attendings, really talk about the key facts, concerns, and how you guys make a decision to use different bone graft products in different areas in the spine. So bone grafting, biologics has been a big part of my career. I spent a lot of time with Vin Sandhu and Joe Lane at HSS, and we did a lot of work regarding some of this early work in demineralized bone matrices, BMP, part of the pivotal trial of BMP, and did a lot of work on animal models for spine fusion. From the rodent model all the way up to the primate model. And we were lucky here actually at UC Davis with Manish Gupta, a legend here at UC Davis. I was so fortunate to work with him. We did primate work also in biologics. So I come from an angle of a 20-year history of really being immersed in this space. So for the residents, when we talk about the conventional model for bone healing, we get tested about this all the time. There are four factors that are incredibly important for bone healing: osteogenic cells, osteoconductive scaffolds, and then osteopromotive, osteoinductive growth factors that are signaling molecules that allow the cellular cascade that initiate healing to occur. And also important is the mechanical environment. Is this a load-sharing environment, a load-bearing environment? What are the features that collectively orchestrate bone healing is something that we should be very familiar with. So right now, if I were to take a snapshot in our Omnicells, and the talk that I really want to give is what does the Omnicell of 2025 look like in our ORs? We have autologous cellular grafts, we have allografts, we have synthetics, we have DBMs or demineralized bone matrices, we have cell-based allografts or stem cell products, and then we have class 3 drug device combinations like BMP and iFactor, and we'll come a little bit to what that FDA class is in terms of the way the federal agencies look at these products. This is a great table, and if there's one thing that I would recommend our residents and fellows to walk away with is this chart. It's from International Journal of Spine Surgery from about 4 or 5 years ago. My friend Celeste Bjornson from HSS put together a great paper reviewing bone graft categories as part of the ISAS study group. And if you look at the category of grafts that we've talked about, I think it's important to understand what the regulatory pathway is, what the mechanisms of action are, and what the available data is. And this is again 2018, and we'll have some discussion about, evidence and data. But I think if you understand what category of bone grafts you have in your institution, you understand what the regulatory pathway is, how stringent that regulatory pathway is, you understand the mechanism of action, I think you can make more informed decisions, site-specific decisions for biologics, whether it's a big deformity operation, whether it's an MIST lift, whether it's an anterior cervical, anterior lumbar. I think we have to think differently for site specificity when it comes to bone grafting. So how should we evaluate bone grafts? And this is something that I think most of my colleagues on this call, as well as nationally, would say that I think we have to have some degree of stringency when it comes to evaluating bone grafts. And I know Bob Eastlack, my good friend, and Greg Mundis, and Rick Price, who's here at our institution, as well as um, many others have looked at what we should think about when it comes to bone grafting options. I think regulatory pathways are important, levels of evidence are important, and we'll admit that there's very little level of evidence. So what's the bare minimum we should get? Whether it's donor or manufactured with regards to product variability, are there any safety concerns? And like Hani was mentioning, the cost of biologics is so extremely high that builds into the institutional pressures that we face with regards to biologics. So I do think it's important to understand what the FDA class is, from the base of the pyramid to the top of the pyramid. The FDA breaks bone graft products into a couple of different levels. The HCTP pathway, or the human cellular tissue product pathway, has about 230 products. You don't really need any FDA data review or for safety or efficacy. No animal or human testing is really necessary. And a lot of our stem cell products and DBMs without carriers belong to that base of the pyramid in terms of the FDA classification. Class 2 devices, about 120 plus products, synthetics, DBMs with carriers. A lot of what we do every day in our ORs as bulking agents, where we need more volume or mass to our biologic products, come from this middle grade class 2 product line. And that requires what's called a 510(k) approval, which requires animal data. And it also requires that you prove substantial equivalence to any predicate data that's on the market. So in other words, if you have a DBM product on the market, if you have a ceramic product on the market, if you have a synthetic product on the market, the company has to give animal data and prove, if not minimum animal data, to prove that there is equivalence in anything that's on the market. And finally, class 3, which there are 2 products available. They're both drug device combination products, BMP and iFactor, or P15 product. They required an IDE, which is investigational device exemption, which basically means they require a robust human clinical trial to prove safety and efficacy in humans. So I think this is important just to understand where products are, and it also, to me, helps me, the more complex the patient, potentially the higher class that I will use. But day to day, for a lot of products that we use, class 2 is still very relevant and very appropriate. We know about levels of evidence, level 1 down to level 5. I won't belabor that point, just being respectful of time. But I wanted to show this slide to Hani and the group, and my good friend Todd Allen's on the call as well. And we've talked about this at our institutions. The cost of bone graft by bone graft category is extremely variable and high when it comes to the class 3 drug device combinations. The stem cells, if you look at it, hovers right in the middle of this cost boom. And if we can tie in efficacy, if we can tie in cost, if we can tie in evidence, we tie in the regulatory pathway, and we can tie in safety, I think we can make informed decisions. So, oftentimes I challenge our residents and fellows, and I say, you know what, in conference, we have to ask what biologic you're going to use and why are we using a certain type of biologic, because that does affect the overall bottom line. So let's go through this exercise of looking at bone graft options through the lens of those 5 particular points: regulatory pathway, levels of evidence, product variability, safety, and cost for DBM, synthetics, cell-based, and then BMP and P15. So as far as DBMs are concerned, They are basically osteoconductive composite matrix of collagen and non-collagenous proteins. They're available in multiple forms. I think this is the highest use that we use in our posterior lateral fusions as a bulking agent. And the reason why DBMs are used or demineralized bone is used once that acid elution of the mineral phase is removed is that residual powder has all the osteoconductive proteins and osteoinductive proteins, I should say, BMP2 and BMP7. But Han Bei, who is also on the West Coast from Cedars, did an incredibly important study that absolutely changed my way of looking at BMPs, where he looked at off-the-shelf analysis of clinically available DBMs. So, in other words, if I'm doing a case in the morning, I'm doing an ACDF, and I pull off a DBM that is on my OR shelf, and I use that. And then in the afternoon, I have a posterior lateral fusion. I pull off the same DBM off the shelf, and I use that. Well, what Bay did was he analyzed BMP 2, 4, and 7 from these off-the-shelf formulations and showed significant inter and intra-product variability of those osteoinductive proteins. So look at these type of DBMs on the left, and then you can see the different lots. So lot 1, hypothetically, I used in my ACDF. Lot 2, I used in my posterior lateral fusion. And look at the coefficient of variation between each lot for any given product. So what that tells us is that a surgeon's reasoned selection amongst products is really not possible because there's so much variability lot to lot between the DBM presence of these osteoinductive proteins. There are a few trials, randomized trials. Grafton's the one that comes to mind that did a head-to-head comparison against iliac crest autograft. So when I look at DBMs, I look at the regulatory pathway as being somewhat not as stringent, right? The level of evidence is very limited. We use it all the time, every day, though. There is incredible product variability, which is donor-derived because DBM comes from donor bone banks. There doesn't seem to be that much of safety concerns, and it's really good in terms of cost. And if we use it as more of a bulking agent with some osteoinductive capacity, then I think it's a reasonable bone grafting option. As far as synthetics are concerned, the synthetic ceramics belong to this category. They have been shown to have some osteoinductive and osteoconductive capacity. They're predominantly osteoconductive. But what I do want to talk about is something that a product that's very familiar with my colleagues from Southern California is Magnetos, which is basically a product that can drive down this M2 macrophage differentiation into an osteoblast. So we know that we have different types of macrophages. M1 macrophage is the pro-inflammatory macrophage, which promotes inflammatory fibroblast proliferation, but the M2, and the phenotype can change depending on the environment, is pro-healing and can upregulate stem cells and lead to osteoblastic differentiation. And that's incredibly important, especially from the Magneto standpoint, is the needle-shaped formulation with submicron, the topography of needle shape can modulate this polarization and push it towards the M2 phenotype for more bone healing. So how does it work? And this is directly from the Kuros, the company, is these needle-shaped formulation of the actual synthetic that drives that osteoblastic differentiation. And in some animal studies, very challenging animal studies in the soft tissue pouch, a canine study, it does show that there is incredible differentiation towards the osteoblastic pathway. So when it comes to clinical evidence for this particular synthetic, it is non-inferior to autograft, published study in Spine, where for a single and multi-level instrumented posterior fusion, there was significant difference in fusion rates, and there was a side-to-side comparison. So I think this is a really important way of looking at synthetics and I think, understanding the basic biology, understanding the cellular mechanism of action, then obviously moving on to animal and then human data is the way I think it should be used. So I would say that when it comes to synthetic bone grafts, and this is Atrax, which is another ceramic that's available to us, I think it's very important to signify that even though we talk about these class 2 drug device predicate products, they're not all the same. That's why I have that asterisk. I think Magnetos has done a great job in having a clinical study that has shown that they do differentiate themselves from the rest of the synthetics that have no data at all. It's consistent because it's manufactured. There are very limited safety concerns. And then cost is obviously a little bit higher given the technological advance. Let's talk about stem cells, and curious to hear what the faculty think about a lot of these allograft, quote unquote, stem cell products. What they are is essentially a combination of osteoconductive carriers and cryopreserved allogeneic stem cells or precursor cells from different sources. The animal data has called into question the function of the cellular component of cell-based. Great study by Jeff Wong and Scott Bowden earlier on with in JBJS about 4 years ago changed my perception. Again, very data driven on what it is that causes that fusion to occur in this rat model, posterolateral model. If you look at that data very closely, it really wasn't the presence of cells that drove fusion. DBM fiber carrier alone gave equivalent, or in some places, higher fusion scores in this group. So was it really the cells that had anything to do with the fusion cascade, or was it really a fiber-based formulation of DBM that led to the fusion? So I've always been a little critical of the stem cell pathway, primarily because of the price index and the lack of human clinical data. And then, furthermore, the data that came out in JBJS with Scott Bowden, Jeff Wong, and Dr. Abadi. I think it was, to me, I sort of hold back on stem cell use primarily because of that. And there are some safety concerns. There have been some reports of transmission of pathogens. So we have to be a little bit more judicious and careful. So this will be a good discussion point for those of my colleagues who use stem cells today. So I would say that the HTTP pathway is the lowest pathway in the FDA cascade, very limited level of evidence. Its product variability is high because it's donor derived. There is a safety concern with pathogen transmission, and the cost is really prohibitive, and the cost pricing sometimes approaches even that of a purified protein. And then let's come down to what we're very familiar with, right? BMP is something that we're very, very familiar with. And oftentimes we get this question. This study was done in in the vein of, well, how do we use BMP in the posterolateral space? Well, we did this study in primates that showed that placing BMP soaked in that ACS sponge for at least 15 minutes, if not longer, longer the better, directly next to bleeding bone encourages robust bone formation. And that, I think, is the way we do it, where we do our decortication, put our collagen sponge, and then we use our extenders and bulking agents over on top of that. BMP is, as we all know or should know, a bone-forming agent that can drive mesenchymal stem cells in the osteoblastic lineage. It's available for spinal fusion applications. And that's obviously some carriers to prevent rapid diffusion. Some of the best studies we have is BMP studies. Some of the best studies we have is because of the ID nature of those studies and requirement for clearance by the FDA. And it all culminated in 2002 with the FDA approving it for anterior lumbar interbody use. But I will say that there have been complications associated with it. And I think Bob and Greg and Todd Allen, who've been around for, 20 years or so, will tell you the same, from training all the way up to practice, that it's not benign. BMP can form heterotopic bone formation, can cause radiculitis. It can cause dysphagia in the anterior cervical spine, not used as much anymore. But I do have some colleagues around the country, when we speak and we talk, that they do use an extra small BMP for anterior cervical fusions, and it's a good conversation to have. I don't particularly use BMP other than deformity cases, but it is our workhorse, right, for more complex cases, smokers, diabetics, et cetera. We automatically turn to BMP. Yoda occurred, right? So most of us who are on this call, who as faculty, remember when in 2013 there was some concern regarding the use of infuse and improper complication reporting. So what Medtronic did was they turned over all their IDE data to Yoda, the Yale outcome database. What was it? The report, Access report. with $205 million of no strings attached funding. And what they did is they contracted two independent research groups to evaluate the quality of BMP studies. And their work in 2013 culminated in two papers. They were very controversial when it came to, well, first of all, they were internal medicine colleagues of ours who did the review of the papers. And what they suggested was that BMP increases the likelihood of fusion with not clinically successful reduction in pain and possibly increased number of cancer cases. This was the Simmons paper. And then the Fu paper said that it's difficult to identify clear indications for spine fusion. This was really damning for us in 2013 when it came down to us getting this blockade from insurance companies when it came down to use of BMP2. So the way I interpreted all that, and this is a separate talk altogether about the YODA trial and the data of BMP and complications, is there's really no evidence between BMP and iliac crest for inducing spine fusion. It was a non-inferiority study in the IDE groups. And both are associated with complication rates for ALIF and posterior fusions. It's higher complication rates anteriorly back then, around the early mid 2000s, primarily because dose and concentration wasn't really studied adequately for the anterior spine. But as far as cancer risk is concerned, and I was really lucky to work with Hari Reddy here in my research here, who was a big BMP7, one of the first people who really identified BMP. And, he would laugh at the cancer risk and he would say there's absolutely no reason why there's cancer. And part of the reason why is I don't think IDE trials are powered to give us epidemiologic answers regarding cancer. So I do think there is a questionable clinical relevance to that concept that BMPs can cause cancer, even though there is a white label warning on the box, and we should be obviously very cognizant of that, especially in younger women of childbearing age and those with prior proliferative cancers. So when we look at this rubric evaluating bone graft options, BMP is very stringent, class 3 PMA. It has substantial level 1 evidence. It's consistent because it's a manufactured protein. And it does have safety concerns, and the cost, I would say, I would probably modify this slide by say the cost is probably a little bit lower now because of the various formulations that have come out in terms of the size of the kits. And finally, let's talk about the last drug device combination, P15 protein, that attaches to type 1 collagen. And their concept is attach, activate, accelerate. It promotes attachment and activation of osteogenic cells, amplifying the body's signaling pathway to promote bone regeneration. They did a cervical study looking at a non-inferiority study as well, looking at P15 plus inorganic bone matrix versus local autograft in the anterior cervical spine, and did show at level 1 evidence pretty good fusion rates that sort of pushed a lot of us to work towards using I-factor in single level ACDFs. Safety-wise, really no difference from regular ACDFs. So there's any adverse event within 72 months post-surgery. There was statistical criteria for safety up to 72 months after. So it has a mechanism of action that is well studied. P15 has been shown in clinical work to have equivalence with regard to standard of care with fusion rates that are competitive, and it's safe to use. So when I look at that, I think that it's somewhat of a bonus that we have, something that can counter BMP potentially. Of course, the lumbar data is the most important thing, and I understand that there's some data going to be coming out later this year regarding that. So, I wanted to, this is a bit whirlwind, and I hope it hasn't been too aggressively busy, Hani, and forgive me if it has. I just wanted to be respectful of time. But I do think that the level of evidence required for FDA approval and clearance is variable. Not everyone requires level 1 evidence, and neither should they, depending on how and where we're using biologics. There are some published level 1 studies that are available, and I really laud the groups that are pushing the envelope on having level 1 studies because we really need that. It's critical to assess level of evidence, regulatory pathway, variability of the product, safety concerns, and cost when it comes to these products. So with that, I really appreciate again inviting me to talk on this, and I look forward to a robust discussion.
Thank you so much, Safdar. I really appreciate it, man.
Of course.
So we've got a few minutes for questions. Again, I think this is a topic that is critically important from the cost perspective alone. And I'll kick it off. I have one question. So one thing that we've been studying is the use of specific implants and how that can impact the cost burden of biologics. So for example, like in the lateral space or in the anterior space using 3D printed porous titanium cages, which have some bioactivity themselves in terms of cellular signaling and just a single series experience. But we basically found in the absence of smoking history or so forth, that if you're using these new bioactive implants 3D printed tie and with some porosity, that you really seldomly need to use BMP, and we just would use either a ceramic or cortical cancellous chips. And I would just wonder if you have any thoughts on that. I mean, a lot of the study data obviously is confounded by the implants used if we're looking at interbody fusion. So does the evolution of implants in the interbody space kind of make you feel like we can be a little bit more liberal with what we use in terms of biologics?
Yeah, I have to laud your group, honey, because I know you and Greg and Bob have studied and published that sort of do we really need biologics in the presence of sort of this activated implant that, especially in the lateral space. So I laud you guys for that data because that's so disruptive, right? Because we oftentimes will, at least in the lateral space, you have to use a biologic. We don't have
Right.
local bone in the lateral space. We do have some local bone in the anterior cervical space, not so much in the anterior lumbar space, but posterior lateral, posterior interbody, we have to use some sort of biologic.
Mhm.
So you showing that in your data that in the lateral space where we're very limited with local bone or autograft tissue, unless you harvest a iliac crest, which I don't think many of us do anymore, that I think was very disruptive data. And that is incredible because it does put the onus on us now to think about site specificity. And I've been a big proponent of site specificity for biologics. So in other words, why would I use the same biologic in the anterior cervical space versus the posterolateral space when I know it's two different healing environments, when I know it's two different areas of transmission of stress. And also, a smoker in an anterior cervical space may be very different than someone who's
Right.
very healthy for a degenerative spondylolisthesis. So I think that there is incredible work that needs to be done with implant specificity and decrease of biologic cost and burden. And your group is really leading the way on that.
It was actually a shameless plug. No.
Not
Um,
shameless.
uh, I just wanted to open up. Does anybody else have any questions for Dr. Khan?
Hey,
Good
Dr. Khan,
morning.
it's Tim. Oh, go ahead.
Sohab from UCI. Sorry to interrupt. Dr. Khan, Hanny, thank you for making this happen. This is awesome. Question about how about gold standard iliac crest bone grafting? When and if we should consider that still? You know, it's an interesting evolution.
I think you muted yourself. Sure. Okay,
But
sorry.
how
Yeah.
about now? Sorry,
Yeah.
Yep.
unmuted.
You're good.
Uh, when should we think about iliac crest bone graft? When is it still the gold standard? Are there site specific indications that you teach fellows residents about? Because I think that's one of the things we should really consider in
Question.
training is we've gotten away from it routinely.
Yeah, that's a great question. And my answer is going to be a little disruptive. Like I think, and I'm eager to have this conversation with Hani, Todd, and Rick, you, Sahib. Like, I don't think iliac crest bone graft is the gold standard anymore. I think iliac crest bone graft is maybe the traditional standard, but
Yeah.
it's not the gold standard anymore. And primarily because when you look at the complication rates that were at least published in the early 2000s regarding iliac crest, I mean, they were very, very high. And again, the way we took iliac crest then was kind of barbaric. I see Dr. Argbania on the a call as well. I'd love to hear his thoughts about this as a as a legend in this field. But I would say that I think it's a traditional standard. I think that the onus is on us, I think, especially when you have don't dividing donor versus manufactured. I'm more towards the school that because we have manufactured bone graft products that show consistency. Even if you take iliac crest, I would argue that it doesn't necessarily mean for each patient it will show consistent fusion. But whether it's a manufactured product, whether it's a synthetic, whether it's a protein, whether it's a peptide, We have to move towards less incisions, less invasive, use as much local bone as we can because we can never throw that away. But if we have more manufactured lack of variability, to me, that's the new gold standard.
And then Dr. Choi, did you have a question as well?
Yeah, that was my question.
Well, if you'll permit it, I have one last question to send us on our way. But the variability in DBMs that you discussed that Bay had published on, do you think that that's due to carriers, or do you think it's just the quality of the fibers itself? Because I know that that's something that I didn't pay a lot of attention to until I became an attending about the different sort of formulations of DBM and how they're not all the same.
Yeah, I think that paper used ELISA, enzyme-linked immune sorbent assay, where they actually used ELISA to extract sort of the BMP and BMP 2, 4, and 7. And so yeah, I think that was, could it have been like within each of those DBN packets a carrier that prevented extraction? Potentially, but then what does that mean clinically? If
Yeah.
it's so hard to do in a lab to extract BMP, then I don't think the body naturally is going to be able to, work
Yeah, I
through
understand your
those
point.
carriers and stuff. So,
Okay. Any last questions for Dr. Khan before we let him get on with his day? I think we're good. Hey, Safdar, I really appreciate you,
hey,
man.
thank
And
you.
I know it's getting close to the holidays, and so folks have a lot of competing things. Hey, Dr. Akbarnia.
Thank
But
you very much. I really enjoyed the talk, Safdar. I think one thing that I think maybe in general we pay less attention is the environment where any substance we use is placed, and I think the importance of technique and preparing the sort of bed for fusion is should be a little bit more thought, because we just come up with stronger substances, a stronger material, and think that you just put it in and they would heal. So I think that probably has some influence in the results, but I enjoyed the talk, and I'm sure there would be much more, uh, research on this, and looking forward to see what you guys are doing. All great. Thank you very much.
Thank you very much, Dr. Bani. Can't agree more. Carpentry before anything. Good surgical indication and surgical site prep before anything. So absolutely, I think that's probably the most important message for the fellows is good carpentry, good surgical indication, proper personalization of technique before any biologic. So thank you for that comment. Absolutely.
Thank you.
thanks,
Have a great
Safdar.
day.
Welcome to the West Coast.
Thanks, man. Thank you, guys.
Yeah, thanks again. Great talk. Really
Thank you.
appreciate it. Have a good one.
Take care, guys.
Bye, guys.